Dr. Jigyasu Singh, please come on the desk. Dr. LP Meena, please come on the desk. And Dr. Soumik Ghosh, please come on the desk. पी लो यार, हर्षित पी लो, क्या करना है? पीते हुए आ जाओ, क्या दिक्कत है?
So thank you so much. So all going well and it's on the time right now. So calling for the last session of today. First talk from Dr. Vikash Agrawal, a very dynamic and awesome cardiologist and speaker and academician from IMS BHU. He will be talking on the latest ESC guidelines update on the infective endocarditis. Over to you, sir, for your talk and deliberation.
Thank you, Dr. Jigyasu. Good evening, everyone, and congratulations first to Dr. Alok for organizing this wonderful conference, wonderful topics, and such an academic feast throughout the day. So congratulations to him. I'll be talking about ESC guideline update on endocarditis. And as we all know, endocarditis is not it's a relatively rare condition that that clinicians see, but it remains a public challenge, public health challenge to manage. And we have this new guidelines of ESC 2023 guidelines for the management of infective endocarditis. Starting with the pathophysiology of infective endocarditis, these three factors are important for the development of endocarditis. There has to be a predisposing condition. Then there is pathogen in the bloodstream, what we call as bacteremia. The portal of entry of pathogens could be the oral cavity infections of the skin, direct inoculation or healthcare exposure. And there is also a factor of immunity of the individual person that is also plays a role in the pathogenesis of infective endocarditis. So the latest guidelines of 2023 follow the guidelines. The earlier guidelines were in 2015. After 8 years, there has been some new data that has appeared in the management of endocarditis, and that has led to the new guidelines which have incorporated this new data. So I'll be talking about, these are exhaustive guidelines, more than 100 pages. I'll be touching on these 5 important aspects of infective endocarditis: the prevention of endocarditis, diagnostic criteria, antimicrobial therapy, indications of surgery, and with more use of implantable electronic devices, infective endocarditis related to these conditions. So coming to the prevention of endocarditis, not everybody is at the same risk of developing endocarditis. So the population can be divided into high, intermediate, and low risk. And this division, the high risk patients are basically patients which have previous infective endocarditis, patients with prosthetic valves, congenital heart disease patients who are untreated cyanotic, or those treated with post-operative palliative shunts, conduits, or other prostheses, and also patients on ventricular assist devices as a destination therapy. These are high-risk patients, and these are the patients who deserve prophylactic antibiotic therapy. For intermediate group patients, it's basically more of preventive measures that are important, but for high risk, its recommendation is antibiotic prophylaxis. Intermediate risk patients are rheumatic heart disease patients, non-rheumatic degenerative valve disease, congenital valve abnormalities like mitral valve prolapse, bicuspid aortic valve, then CID patients, and hypertrophic cardiomyopathy patients. Coming to the antibiotic prophylaxis in patients with cardiovascular disease, especially undergoing orodental procedures at increased risk for endocarditis, the guidelines have a class 1 recommendations, and they recommend general preventive measures for intermediate and high risk patients of infective endocarditis. Antibiotic prophylaxis is recommended in patients with previous infective endocarditis, patients with surgically implanted prosthetic valves and with any material used for surgical cardiac valve or repair, patients with transcatheter implanted aortic and pulmonary valvular prosthesis, and in patients with untreated cyanotic congenital heart disease who have been treated with transcatheter procedures or surgery with post-operative palliative shunts, conduits, or other prostheses. For patients who have undergone surgical repair in the absence of residual defects of valve prosthesis, antibiotic prophylaxis is only recommended for the 6 months after the procedure and not always. These are the general preventive measures the guidelines recommend in high and intermediate risk patients of infective endocarditis, and they include tooth cleaning twice daily or at least twice yearly, cleaning, dental cleaning at least twice yearly. Then strict cutaneous hygiene, strict disinfection of wounds, and for any bacterial infection, curative antibiotics. But they recommend that there should be no self-medication of antibiotics. There should be strict infection control measures for any high-risk procedure, and there is discouragement of piercing and tattooing in this high and intermediate risk patients for infective endocarditis. The prophylactic antibiotic regimen for high-risk dental procedures, they have divided into two. Patients non-allergic to penicillin or ampicillin should receive a single dose of antibiotic 30 to 60 minutes before the procedure. It could be amoxicillin, ampicillin, cefazolin, or ceftriaxone. For patients allergic to penicillin or ampicillin, cephalexin, azithromycin, or clarithromycin, doxycycline, and cefazolin or ceftriaxone can all be recommended. They have removed clindamycin, which was there in the earlier guidelines, that has been found to be at more risk, so they have removed clindamycin. The basis of using this prophylactic antibiotic regime is basically tackling the oral streptococci that is there in the oral flora. Coming to the procedures at risk with demand attention, these could be dental procedures, non-dental procedures, or cardiac procedures. I'll be covering the dental and the non-dental procedures. The dental procedures basically have a class 1 recommendation in high-risk individuals, and this include invasive dental procedures. Invasive dental procedures means manipulation of the gingiva or periapical region of the teeth, and also includes dental extractions and oral surgery procedures. So these are a class 1 recommendation. For non-dental procedures, the earlier guidelines was a class 3 indication. Now they have changed it to class 2B because of some observational studies that have shown that procedures like blood transfusion, dialysis, bone marrow aspiration, GI tract manipulations or procedures have shown to increase the risk of infective endocarditis. So now it's a class 2B indication for respiratory, gastrointestinal, urinary tract, skin or musculoskeletal system therapeutic procedures or diagnostic procedures which could receive systemic antibiotic prophylaxis. Coming to the diagnostic criteria of infective endocarditis, and these guidelines have brought about some change. The diagnosis in infective endocarditis is based on clinical suspicion, consistent microbiological data, infective endocarditis related cardiac lesions on imaging. These are the three most important things that help in the diagnosis of infective endocarditis. And the latest 2023 guidelines have given us the modified diagnostic criteria of infective endocarditis, which depends on the major and minor criteria. The classification of infective endocarditis could be a definite case, a possible case, or a rejected case of infective endocarditis. And they have also introduced new specific diagnostic algorithms for native valve endocarditis, prosthetic valve endocarditis, and CIED related infective endocarditis. For microbiological diagnostic algorithm, once a suspected case of infective endocarditis, we draw blood cultures. 3 samples typically from 30 minutes apart from different sites are sent for cultures. And if the culture is positive for a typical organism of infective endocarditis, they recommend identification by a specific test called Malditoff MS, which gives the particular diagnosis and the particular bacteria that is responsible for infective endocarditis, and we do antibiotic culture and resistance. For bulk culture negative infective endocarditis, serologies could be done, specific PCR tests to diagnose Coxella, Bartonella, Aspergillus, or different organisms. And finally, for intracellular bacteria or fungi, these should be excluded before giving a diagnosis of non-bacterial endocarditis, which could be related to antiphospholipid antibodies or antinuclear antibodies. Coming to imaging, echocardiography still remains in these guidelines, the first line of imaging modalities. However, there are some very important changes that are there in these guidelines. Transthoracic echo is the first line imaging, but they have also given transesophageal echo also as a first line or class 1 recommendation for infective endocarditis. And the reason they have given transesophageal echo is that it can provide additional information on characteristics of the vegetation, valvular lesion, or perivalvular lesion. So, according to these guidelines, the revised, one of the revised guidelines is that TOE can be recommended in patients with suspected infective endocarditis, even in cases with positive transthoracic echo, except in isolated right-sided native valve endocarditis. And this can give us incremental information apart from transthoracic echo. So transesophageal is also a class 1 indication now. Again, the most important changes in the guidelines with regards to diagnosis is advanced imaging techniques have achieved the same level of recommendation as echocardiography, and now what they recommend is a multimodality imaging in patients of infective endocarditis. Advanced imaging techniques, CTA, FDG PET, MRI, and WBC SPECT. These 4 imaging modalities have all achieved class 1 levels of recommendation. Cardiac CTA is basically recommended in patients with possible native valve endocarditis to detect valvular lesions and confirm the diagnosis of infective endocarditis if echo is not confirmatory. FDG PET and CTA are recommended especially for prosthetic valve endocarditis to detect valvular lesions and confirm the diagnosis of infective endocarditis. And the reason is that cardiac CTA has been found in studies to be more accurate to transthoracic echocardiography for detection of lesions of infective endocarditis. Then they also recommend CTA, cardiac CTA for native and prosthetic valve endocarditis to diagnose paravalvular or periprosthetic complications if echocardiography is inconclusive. Whole body imaging is also recommended. It's class 1 indication for somebody who has a peripheral embolic lesion or peripheral lesion elsewhere in the body, and whole body imaging with a CD, CT, FDG PET, CT or MRI are recommended in symptomatic patients with both native valve and prosthetic valve endocarditis. Even in asymptomatic patients, this has been recommended as a class 2B recommendation. So these are computed tomography images for cardiac and extracardiac complications, and this is CT is becoming one of the most important investigations. This shows aorto left atrial fistula, a pseudoaneurysm, and they can also detect peripheral lesions like brain abscess, splenic infarct, renal infarct, and aortic aneurysms. PET scan has come up in a big way, and FDG PET is now recommended mostly for prosthetic valve endocarditis to detect perivalvular lesions, perivalvular abscesses, and periprosthetic abscesses, which are more readily detected with PET scan, and also for CIED related endocarditis, where it is found to be very useful. Just the protocol used in PET scan for infective endocarditis is a bit different from myocardial PET scanning. There is a inflammation imaging protocol that is followed that is different, and PET CT fusion in endocarditis can give us more information in patients of endocarditis. So they have proposed this new 2023 ESC modified diagnostic criteria. The major criteria here is blood culture positive, that is the same as before, but the most important changes here are imaging positive for infective endocarditis, and here they have included all the 4 imaging modalities: echocardiography, TTE and TOE, cardiac CT, FDG PET, and WBC SPECT, all 4 to detect valvular, perivalvular, periprosthetic, and foreign material anatomic or metabolic lesion. Metabolic lesions due to FDG uptake or WBC SPECT, characteristic of infective endocarditis detected by any of the following imaging modalities. So all 4 imaging modalities are now included in the major criteria. The minor criteria remain the same. So for classification of infective endocarditis, a definite case is 2 major criteria or 1 major and at least 3 minor criteria or 5 minor criteria. A possible case would be 1 major and 1 or 2 minor criteria, or 3 to 4 minor criteria. So this is how you classify infective endocarditis. Now these are the specific algorithms. I'll just go fast on this, how to diagnose native valve infective endocarditis. The most important here is in patients who have a possible diagnosis of infective endocarditis, here they have given a class 1 recommendation, as I already talked, to cardiac CTA because of its more accuracy to diagnose valvular lesions. For suspected paravalvular complications, and if the TOE is inconclusive, cardiac CTA is class 1. For symptoms suggesting extracardiac complications, you could use brain and whole body imaging with a CT, FDG PET, or MRI. For prosthetic valve endocarditis, here you could use, for possible endocarditis, cardiac CTA or FDG PET, because FDG PET is considered to be more useful in prosthetic valve endocarditis, and both have a class 1 recommendation. For suspected paravalvular complications and TOE inconclusive, cardiac CTA is the class 1 recommendation, and symptoms suggestive of extracardiac complications, you can go for CT, FDG PET, or MRI. For cardiac device-related infective endocarditis, for possible cases, here PET CTA is considered to be the class 1 indication to detect pocket infections and or pulmonary embolism to make a definite diagnosis of infective endocarditis. Coming to antimicrobial therapy, I'm not going to the details, just a few concepts that these guidelines tell us. We already know about the prophylactic, empirical, and targeted antibiotic therapy, but the guidelines is the introduction of oral antibiotic therapy, or OPAT. And what these guidelines say, that they have divided this antibiotic therapy into 2 phases, early critical phase or continuation phase with resting bacteria. And the continuation phase, when the patient is stabilized, you can go over to oral antibiotic treatment. And this has been the new paradigm in this guidelines, the new outpatient paradigm for antibiotic therapy, which holds a class 2A level of recommendation, is that outpatient parenteral or oral antibiotic treatment should be considered in patients with left-sided infective endocarditis caused by these typical organisms who are receiving appropriate IV antibiotic treatment for at least 10 days or at least 7 days after cardiac surgery, are clinically stable, and who do not show signs of abscess formation or valve abnormalities requiring surgery or TOE. So these guideline recommendations came from the POET trial, which compared IV treatment to oral treatment in stabilized patients. And how do you define stability? They have given a definition how to define which patient can be discharged on oral therapy. The definition they have given for stability is satisfying response to treatment with no fever for more than 2 days, a CRP level that is 25% of max measured value or less than 20 milligram per liter, and leukocytes less than 15. They have been treated with IV antibiotics for more than 10 days and 7 days after valve surgery. These are the patients who could be discharged and kept on oral therapy, and the POET trial showed a significant at 5 years follow-up, there was a significant benefit of oral treatment with regards to primary outcome of death, emboli, unplanned surgery, or relapse. And the oral group was discharged 7 days earlier. So now we have an oral treatment even for infective endocarditis in stable patients that can be done. Then coming to indications of surgery, I think indications of surgery are heart failure, uncontrolled infection, and prevention of embolism. I'll not go into the details, but they have stressed about early surgery in most of the patients of infective endocarditis who are complicated, and surgery is also recommended for early prosthetic valve endocarditis with new valve replacement and complete debridement, which is a class 1 level of indication. And so the guidelines basically said that earlier intervention, non-delayed surgical management after ischemic stroke, expanded indications for surgery in ischemic stroke, surgery recommended for early PVE, and more liberal use of surgery for prevention of embolism. Then this is the final slide, the electronic device-related infective endocarditis, where they have given this algorithm of when to extract these devices, and for CIAD related infective endocarditis, and how about the duration of antibiotic therapy, and then how to reimplant CIAD in these patients of CIAD related infective endocarditis. So the key takeaways from these guidelines are that there is increased level of recommendation and a clearer definition of prevention and prophylaxis of endocarditis in higher risk patients, an increasing role of non-echocardiographic advanced cardiac imaging techniques in the diagnosis of endocarditis, and these techniques achieve the same level of recommendation as echocardiography, Use of other imaging techniques either for the diagnosis of cardiac involvement or of different lesions is highly encouraged in patients of infective endocarditis. In patients of prosthetic valves and CIED, echocardiography is particularly limited and other imaging techniques are strongly recommended, and they have more precisely defined indications for surgery and timing of surgery and more defined criteria for diagnosing and managing CIED associated endocarditis. Thank you.
Thank you so much, sir, for such a elaborate and crisp talk. Such a fine talk you have given. Now we are open for any discussion, any questions if you have.
Sir,
Thank you,
I have a question. Is there any role of colonoscopy, routine use of colonoscopy in patient of infective endocarditis?
Actually, colonoscopy basically for high risk patients who require prophylaxis for infective endocarditis. Colonoscopy earlier in the previous guidelines, gastrointestinal interventions were not included. They were a class 3 recommendation for infective endocarditis prophylaxis, but now they have changed it to class 2B, and colonoscopy, upper GI endoscopy, genitourinary interventions, all are now class 2B. You can give antibiotic prophylaxis in high risk individuals now undergoing these procedures. High risk individuals are basically patients with congenital heart disease, valvular prosthesis, patients with previous infective endocarditis. These deserve now to have endocarditis prophylaxis, which was not there in the previous guidelines, and this has been based according to few studies in the past 2-3 years, which have shown that they increase bacteremia in high risk patients, and these patients are prone to develop infective endocarditis.
One more question. If the patient is responding to antibiotics, diagnosed case infected, how frequently we should go for echo?
Actually, there is a protocol they have given in the guidelines. You have to go, you have to judge by how he is behaving clinically. Fever is the most important thing, how the fever is responding, and also of the size of vegetation, how the vegetation mobility and the size of vegetation is important. And for patients having complications with periprosthetic area problems or paravalvular problems, how these are responding to treatment. Echo is most important. They have given more stress to transesophageal echo in these guidelines because they are more sensitive to detect perivalvular problems. It's not only the perivalvular problems like abscess, perivalvular prosthetic abnormalities, and valvular function. Valvular function is more clearly seen with transesophageal echocardiogram.
If they are responding to antibiotics well, clinically, should we go for repeat echo?
Yeah, they recommend repeat echo. Now with the advent of oral antibiotic therapy, patients who are stabilized on IV antibiotic therapy after 10 days, minimum 10 days of hospitalization is necessary for all infective endocarditis patients where they are given IV antibiotics. What they recommend now, after 10 days, if there is no fever and the stability criteria is met, which shows that there is decrease in counts, the patient is stable, there is decrease in CRP levels, these patients should mandatorily undergo a transesophageal echocardiogram to see the size of the lesion and the paravalvular tissue and the paravalvular and the valve function. And if you are satisfied that that is stable, then these patients can be discharged and put on oral antibiotic therapy for the further treatment of 2 to 4 weeks what they require, and they can go home. And this was because of the POET trial that they have now incorporated in the guidelines, so that they are at home and the cost is less, they have a better, and it was shown that the all-cause death was decreased because of this kind of a treatment when they are going home and they are stabilized.
Rightly said, sir. So if there are, the main thing is that with the 8 years of guidelines that we have changed, I see that the OPAT therapy and imaging modality, this has changed very much, and this is now the paradigm of the treatment of infective endocarditis. Yes, sir.
So, infective endocarditis, clinical follow-up is also very must. If your fever is responding within 72 hours with treatment, then you should revise your diagnosis of infective endocarditis. One important thing. And imaging becomes important when you are dealing with the aortic valve endocarditis, because chances of going sudden into block because of its proximity to the bundle of His. So in aortic valve endocarditis is very much important to follow with the, especially with the help of transesophageal echocardiography or CT angiography. In mitral valve, you may follow, ideally you should follow, but vegetation size, even if your patient is responding, it may remain same. And sometimes its size may increase even also. So the clinical follow-up and your count and ESR is also very much important. But in case of aortic valve endocarditis, because they may suddenly go into the block, AV block, that can lead to the collapse. So looking for the paravalvular abscesses is very important. So that is important.
And the chances of embolism are most
In
when
a-
they start antibiotic treatment. So you have to be very careful that you have a small vegetation that embolizes, you won't get a vegetation.
And we
Chances
should
of embolization is maximum with the AML, anterior mitral leaflet of the mitral valve.
And we
It is
should
not
al-
with the aortic valve as we expect.
And we should also sensitize our dental colleagues also regarding prophylaxis, because it is very important. Lots of dental procedure going on. After dental procedure, they give antibiotic, but before it is very important to give prophylaxis.
Prophylaxis is
Thank you so much, sir, for such an
Sir,
interesting discussion.
Dr. Vikash,